Well, hi everyone. It's great to be here to talk about some of the 5G related health and social care challenges and how 5G is changing the world for health and social care. I hope we're going to have a good debate and discussion today about some of the opportunities and challenges. And one of the areas I'd really like to start with is an area that's always troubled me. So obviously I come into this from a NHS background, not a social care background, and it'd be lovely to hear about some of the differences from those of you who are more embedded in social care. But from an NHS perspective, one of the challenges often is that we tackle things technology first. Somebody comes along with an exciting piece of technology. Here's some AR or VR. What would you like to do with it? Where would you like to put it? How's it going to change things? And I wondered what the panel's view is on whether there's been any of that with 5G. 5G has had a really high profile and a really high branding. DCMS have invested in it very heavily for good reason. But do you think that we are really using 5G the right way around? Are we looking at the challenges that health and social care faces and saying, how can we tackle those with 5G? Or is there any evidence that we've gone, where can we fit 5G? Can we squeeze it in somewhere and tackled it the wrong way around? So I'd be really interested to hear some of your views. And perhaps Anne and Rosemary, I could start with the pair of you, since I know that you do have a good, strong social care element to what you've been doing in Liverpool, and ask you how you feel about that positioning that I've just set out.
We very much started because I'm a commissioner in adult social care for Liverpool City Council, and part of what I commission is the telecare services. And when I learned a couple of years ago that the analogue telephone line was going to be switched off in 2025, we started using LoRaWAN and other ways of trying to see if we could get digital sensors, etc., in people's homes and monitor their well-being without using traditional telecare equipment. And IoT and LoRaWAN that we were using, I think, have got place in part of that. But what we found was if you fell, we have a sensor that could tell you fell and can ring a sensor. And then when we rang that person back, they were lying on the floor listening to the phone ring. And there's nothing worse than lying, needing help, knowing that if you could only reach your phone, you could speak to them. So the restrictions on the data packages that IoT can carry meant that we needed to look for something that had voice. So we actually actively looked for something, and so that's when we found 5G and the whole opportunity of our own private network. So that's very much why we started. So we haven't been driven at all by the technology. We were driven by the opportunities that 5G gave to give us good connectivity when the analog systems closed.
So that's really interesting, because there's two separate parts there you've described. You described that the impetus was the disappearance of analog, and that said, right, what are we going to do? How are we going to deliver service? But it also sounds like as a consequence of that, you had to create and look for fresh solutions that you wanted to make, and 5G came to rescue in terms of delivering those solutions.
Rosemary, do you want to talk about the adoptionist readiness level?
Yes. Yeah, just to add to what Anne said, really, and before we came into the 5G project, I think the important thing in all of this is having a good understanding of the problems and the challenges you're trying to fix, and not having a technology push. So prior to any of the 5G, we worked together with Anne on the digitisation of domiciliary care services in Liverpool. So we'd introduced digital care records and smartphones for the care workers. And I think what we'd learned from that programme was that we have to take a view that this is a big programme of change management, and it's not just about introducing technology, it's actually about changing how the service is delivered and making sure that all those wraparound services are there as well. So I think we've taken the view all the way along that it's very much not a technology push. It has to be solving a problem. And what we did as a result of that digitisation of domiciliary care was we developed something called an adoption readiness level. so an ARL that sits alongside a technology readiness level. Because we have in the cluster, we work with technology companies, health and social care. So we do see a lot of technology products and ideas that are making good use of new technology, but are not actually solving a real problem that exists at the moment. So the adoption readiness level tries to assess how people have considered, is this going to solve a current problem? How is it going to work with what's there? Who's going to use it? What analysis has been done of the stakeholder views and how many stakeholders have been involved? Because in social care and in health, it's not just single stakeholders. You have what we call a stakeholder chain, where any of those stakeholders who aren't behind it can actually, block the introduction of that. So it is very much about focusing on adoption very early on and having a good understanding of the need, as Anne's outlined, that you're addressing.
So I think there'll be a lot of people listening into this who will be excited by the adoption readiness level. If people want to get engaged and to use that approach, how do they do that, Rosemary?
It's on the eHealth Cluster website. So just go to ehealthcluster.org.uk and it's links there on the front page of that website.
Okay, so both of those made it sound like my fears are unfounded. Maybe I've been tainted too much by some other things that have happened in the NHS. But both Anne and Rosemary are in a very urban and different area than some others. Gary, you're out in the sticks in a very rural area and using 5G in a rural environment. Are there any differences in relation to the topic we're talking about?
Absolutely, Adrian. Thank you. Yeah, and I think we could talk about this for the whole of the time we're together this afternoon. We do face some very specific challenges in very rural areas. Dorset isn't alone in that. There are many others, Yorkshire being one of them, I'm sure. I'm not an expert from a health and social care point of view. I've got a telecoms background. And in fact, the 5G Rural Dorset project is a rural connected communities testbed and trials programme, part funded by DCMS. And one of our objectives is to look at how we can build what we call stackable use cases. So to some extent, I think I need to put my hand up, Adrian, and admit guilty as charged, because that's exactly what we are doing. And I don't, that's fine to do that in some situations. So, the justification for spending money on rolling out 5G infrastructure is likely not going to be there for the mobile operators if for any 1, 2 or 3 use cases. We're going to need a number of what we call stackable use cases in different sectors to justify that expenditure. And so to some extent, we are bringing technologies to the table and saying, what can we use this for in your area? But that does sometimes bring some interesting ideas to the fore. So, for example, in Dorset, we have very poor mobile coverage in various parts of Dorset Council's area, which means that things like helplines and things like that for vulnerable people living at home aren't always a solution, and they may not be able to afford or have any broadband connectivity either. So you can see there's a perfect storm there of disaster waiting to happen. What we've discovered by working with our project partner Vodafone on the 5G Rural Dorset project, though, is that we've got almost very, very close to 100% NB-IoT coverage across Dorset. So with NB-IoT being a 5G technology, that's allowed us to start to look at doing things very differently, and talking to colleagues in the tech-enabled care team at Dorset Council has opened up some possibilities, and we're opening the eyes of people within Dorset Council to ways of doing things that they wouldn't previously have considered. So I think you're right to be concerned, but I think there's maybe a hybrid answer that comes along, which says, these are our challenges from a health and social care perspective. These are the problems we've got, the challenges we face. And then, like we're doing now, sitting around the table and saying, well, this is the technology we've got, and these are the things that we can do to address those challenges. And there will be some wins in there that help to move us forward.
Yeah, I think that's a good point. I think you have to have both sides of the coin here, don't you? It's no good saying what's the challenge and we'll go away and see if we can find a solution for it. If you take NB-IoT as an example, you want to be able to go to people and say, look, this is what NB-IoT is. Here's some things that you could do with it and excite people. Here's something that's been used for in manufacturing, say. How could you use this in health and social care? So you need both of it, don't you? You need a bit of a technology push and a bit of maybe it's 80-20. It's 80%. What are the challenges we're trying to tackle, and can 5G technologies solve them? and the other way around, can we do a bit of pitching of what the technology is? And in Yorkshire, Nick, so every part of the country has got a mix of urban and rural. The balance is different in different places. Maybe you are kind of in the middle of the two extremes that we've got here, that you've got some big conurbations in Yorkshire and some rural areas, unless I've got it wrong, Nick.
No, that's yeah, that's very true. There's I think something of the region of about 15 or so varying size market towns that do make up the main sort of urban areas. You've got places like Harrogate, Scarborough, etc., being the largest ones, but equally geographically the largest county in England in terms of a geographical area. So I think really very similar message to what Gary has highlighted really has been the challenge, I think, for the Many project, which has been a case of looking for use cases. And it is a case that we want to trial this technology, and it is about matching that up with use cases. So slightly different sort of approach perhaps to the other teams on here. And we've looked. I'm just going to stretch the net a little wider here, but we've tried to be creative with our use cases. So we've looked at things like adult social care and what improvements we can do around service delivery. We've looked at how we can work with NHS partners in the area, and we've also looked at isolation as well and loneliness as a theme. So they were the sort of main health and social care aspect to those use cases. And we have struggled a little bit from a technology perspective in terms of actually getting a network up and running. But that aside, we are ready and primed to move as soon as that is up and running, with a number of quite good, I think, innovative use cases where we're looking to trial things like video appointments with the local GP practice in Leyburn. We're also working with a mental health consultant from the Tuve NHS Trust, that's Tees, Esk and Wear Valley, which covers the area that we're looking at around Middleham. It's called the Cover Valley. And we're looking to do a piece of work which will pick up on not only the sort of mental health aspect, but also around isolation and loneliness. And we've come up with basically it's a piece of hybrid research really that we're hoping to do with real people in the community around their experiences during the COVID pandemic and what that meant for them in terms of things like isolation, loneliness, mental health, etc. Because everybody has a story to tell, I'm sure, on that, and where we can then bring the technology and where we can then support both the healthcare professionals and the social care professionals in improving the services that we deliver to the people in those communities, and how those people in the communities can then equally benefit from that. So we're very much looking at how we can deliver services differently, and certainly a concentration at the moment has been around doing video appointments and video assessments and things like OT assessments with some of our our social care professionals, and things like mental health assessments, which are certainly quite challenging when you're doing them over the telephone. They work really well when you're in a face-to-face setting, which has obviously been a challenge for the last 18 months. And it's looking at how we can then introduce video into that and actually utilize that to help deliver hopefully improve services. So that's really been the story. I think we've identified a number of geographic areas where coverage was really poor, and we are looking to move into the next area that we identified imminently. There's some planning permission and other things happening around that at the moment, and we are then hopeful that we will bring in quite a large cohort of local people in the community who are currently in receipt of adult social care, and we'll be able to progress more of that sort of story really. We have had a bit of a challenge in the Cover Valley in that there aren't too many people currently in receipt of social care. So what we've tended to do for that particular area is concentrate on some of our other use cases, which obviously aren't really part of the subject matter for today. So I'll be quiet
right,
now.
well, thanks so much for that, Nick. You mentioned COVID in there, and I want to come back to COVID a little bit later on and how it's impacted both the take-up of 5G and what might happen in the future. But before I go to that, just wanted to pick up on something that, in a sense, Gary and you have both touched on, and Anne and Rosemary, which is about the diversity of use cases. And that phrase that you used, Gary, about mobile operators need stackable use cases. You know, they need a set of things that are going to make this commercially sensible. And it's not just on the operator side, it's true on the user side too. You know, what we've seen, I think, so far is a great set of proof of concepts, you know, some really good pilots, and in some cases, some good initial scaling of those pilots. But if we're really going to make impact, it has to work both for the mobile operators, but also for the NHS and local authorities. Got to be able to see that the commercial models here stack up and enable delivery of a long-term scalable service. And I think there are a lot of changes going on in the health and social care sector at the moment. Gary, you said you're not a health expert, but you must have seen what's been happening with integrated care systems and how that's changing the whole landscape of the commercial arrangements for the delivery and transformation of health and social care. So how is all of that, how is all of that change affecting us and affecting the ability to deliver the sort of change that we're looking for? How will integrated care systems impact on what we're trying to do? Are they an enabler or a barrier? How does that feel? I could pick on someone, but I'm just going to open it and say, does anybody want to pick that up?
Oh, I don't mind going.
You see, I should have picked on someone. Anne,
yeah,
you go first.
I think what I see it as a long-term enabler, because, for example, in our first, we had a phase 1 testbed and trial with our 5G network, and one of the use cases we had was a video med management device, which greatly reduced the NHS medication bill. Lots of people, as they get older living at home, have got carrier bags of tablets that they haven't finished their blister packs of, and there's actually several million pounds sitting in people's carrier bags around the country of medication. So we were able to, by having a link to a pharmacist, watch people take their medication, answer any of their medication problems. You know, lots of people were taking tablets they didn't know what they were taking them for. They got all of that resolved, and the actual medication bill was actually reduced quite significantly, and we did make lots of savings. Now that is, you know, funded through social services, but the benefits for it, and a lot of the benefits that happen in the community end up on the bottom financial line of the NHS. Yeah. And I think an integrated care system is really exciting, and it will offer us the opportunity to stop having the arguments over you pay for this and I'll pay for that. And I think that is to be welcomed. I am very concerned about the way it's going about and the structures that are being formed at the moment. And I think it could have done with a bit more debate and a bit more bringing on of the social services, because at the moment it does seem to be a big drive by the NHS, and you know, the press don't help either by saying, you know, the NHS grabbing the social services money just fuels the issues. But personally, I think it's something that we would welcome a lot, and I think it will resolve quite a few of the issues.
Yeah, I agree. I think that the way you describe that, you know, the benefit sitting somewhere different from where the expenditure is always been the challenge. Yeah. And I hope you're right that the integrated care systems will solve some of that. It may take a long time before we get there. Is it causing us any barriers at the moment? Are there some 5G projects that we're trying to undertake where we're unable to do so because of that mismatch between who's got the cash and who gets the benefit. That may be not what you were about to talk about, Gary, so I'll go to you next.
Yeah, no, well, as usual, Anne's hit the nail on the head, as she often does when I hear her talking. I think there's a huge opportunity personally. In Dorset, we face a challenge. More than 50% of our annual budget goes on the things that we're talking about now. That's a huge motivator. We've got the highest average age of residents of any unitary authority in the UK. So that combined means that we're spending an awful lot of money on keeping people safe at home. And so that comes with a huge opportunity by using things like approaches like integrated care to make them more efficient, to stop wasting money on medicines that aren't being used. So if any of you have visited Dorset, you'll know that it takes approximately twice as long to get somewhere than it seems to anywhere else in the country. Now, what that means is a GP jumping in his car or her car to drive to visit a resident, either at a care home or at home, is taking time out of their calendar that they then can't spend with other patients. So using things like remote patient appointments, monitoring people's vital signs or whatever we might call them in care homes, and being able to hook people up to equipment that will allow the GP to make very swift diagnostics and determinations about what's wrong with them, can all help to drive down the cost of caring for people. And I think that's where there are some real opportunities everywhere, but in particular, that's highlighted in areas like Dorset and rural areas where the cost of caring for and getting to people is higher.
Yeah, so I completely agree, Gary. And by the way, I was on holiday for the whole week in Dorset last week, so I know what you're describing. Not that anybody would need to go anywhere because it's beautiful wherever you go. But the scenarios and use cases you just described are perfect examples, though, of the challenge too. So you say to a GP practice supporting a care home or a primary care network, here's a set of technologies that are going to reduce your travel time, enable you to respond remotely to a need in a care home or to do a home visit remotely. And then the question still arises, who's funding that? Is the care home funding it because of the benefit that it gets? Is the NHS funding it? And does the GP practice care? Because it does care, but from a funding perspective, it's the number of patients that makes a difference to its funding, not how long they spend traveling between. So there are a lot of variables in there that still make it difficult to sort some of that out. But we're absolutely right. I think we're all agreed that 5G is what's going to make the difference in that transformation. It is the route to delivering those transformed services. We've just got to get round some of these commercial challenges. Nick, if you have anything to add to that, please do. Otherwise, I'm heading in the COVID direction.
That's fine. No, that's covered everything.
Okay, so let's just go COVID a little bit. So inside the NHS, there's certainly this realization that and the phrase is often quoted that COVID has made 10 years of change happen in 6 months, and we've really accelerated the sorts of changes that we need. The video consultations that Gary and Nick and others have already mentioned have all been accelerated by COVID. Is that, in terms of us using 5G in exciting ways in the future, do we think we can sustain and take advantage of those changes, or are we going to see it back off again? And just to put my own perspective on this, because I'm asking you for yours, but haven't had a chance to put mine in. I see in a lot of cases people thinking they've ticked a box now. We're using video consultation 90% of the time. We'll say parts of the NHS. Isn't that great? Whereas really, it's only the first step on a journey to much more telemedicine, much more remote diagnosis, not just remote consultation, the delivery of diagnostics in the home. So there's a lot more to be done, but I worry that as COVID eases off, that we might see some of that urgency go away. Does it feel like that to you? Or do you think we've got accelerated change here to stay? Nick, I'm going to go to you first because I missed you out on the last one.
Okay. I think that's a really interesting question. I think in some areas, having spoken actually to a number of GPs, that there is still quite a preference, both from a GP and from a patient perspective, to actually have that face-to-face time, which obviously has been difficult during COVID. And secondly, actually by telephone is still a popular medium as well. So I think there is still a bit of a challenge, even though the technology is there and it's good and it works for around those video assessments, those video appointments. So I think there is possibly a tendency that we might start to revert back to how we were before in some cases. But I think what might be interesting is actually, like any other technology, the more it's used for all sorts of other scenarios, I think it then becomes the norm. So I think whatever maybe retrograde steps that might happen, as a result of people's natural preferences, might be actually countered by the fact that having new technology and being able to do things in other aspects of your life faster, quicker, easier, will naturally start to embed that as just the norm. So I think it's here to stay. And I think, but it will be bolstered by other activities that we undertake.
So I think that's really interesting, Nick. And there's a relation again to the stackable piece here, because I think there has been a tendency to look at specific point solutions where we need 5G connectivity. And if you just look at the single point solution, you can't really justify the cost and the commercial. Well, and so what we have to be doing is, and this goes back to the ICS, is we have to be looking at the system-wide need and saying, if we do a step change, can it deliver a lot of things at once? And yet, for now, we're coming at it from point solutions, from proofs of concepts and so on. Gary, I can see you're itching to add to that.
I'm always
maybe I've misinterpreted.
No, not at all. I've always got plenty to say, Adrian, as you know. I'm fascinated with this. I'm always the optimist. I see huge opportunity in this. But one of the things I think is very easy to skip over or not think about necessarily is it's not just about providing the connectivity. So, we talk sometimes about the digital divide. The fact that we've got an older than average population in Dorset means that many people that are in need of this care are not digital natives. That they haven't got the skills necessarily to use all the physical devices, but more importantly, they may not have the motivation. I've been phoning the doctor for the last 30 years and it's worked fine. Why do I now need to use a tablet if I want to talk to the doctor? Yeah. And until that, it's going to take time for the older people to get younger, if you know what I mean. It's generational. Now, we can work with people to try and help them. We can provide lots of facilities, but you're never going to get 100% adoption. So you are going to have to cater for the people that won't, for whatever reason, want to move over to a new way of doing things.
And we mustn't, exactly as you say, Gary, we mustn't just think that because something is new and exciting, that it's better. So that exactly as you just said, the telephone consultation works a huge percentage of the time. So let's not swap it for something else just because we can. If it works, let's keep with it and use the 5G solution where it really is needed, where it really does add value. And that may be to certain types of consultation, to other types of telemedicine, and to remote monitoring as well. Rosemary and Anne, anything you'd like to add to that?
Yeah, I'd just like to say a couple of things. So on your first point, you were asking about COVID and how that's sort of changed things. There's a couple of areas where I think that has changed things a lot. And one of the areas is highlighting the work that care homes and care providers do, social care providers, which has really sort of come to the fore and helped, I think, people's understanding of the sector. So I think we've struggled for a long time to get recognition for some of the work that's done within the social care sector. And I think in terms of technology, the care home sector in particular is really complex. And, I think the figure is that only 10% of care homes are actually run by local authorities or the NHS. The rest of them are small private businesses, charities, or groups. And they really need help in affording that connectivity. So about that connectivity being affordable. So I think that's something that's come out and come to the fore a lot more. And I think also the other thing we have to remember, which has been highlighted, I think, in health terms, but also wider, and perhaps bringing in education as well, is that things like remote consultations are fine. And like Gary said, not everybody, we won't get full adoption of those. But on the other side, you need a good connection at both ends to be able to do that. So we also have to be aware of people who can't access those services and make sure that we're not increasing inequalities.
Yeah, absolutely. And I think that's why, going back to the Internet of Things and assistive living devices that you touched about before, that's why those aspects have a really important role as well, because there will always be people who either don't want, for the motivation, education or confidence reasons that you took on, Gary, even if they've got the connectivity, may not want to use some of the services if the connectivity is there, but we may still be able to support them with 5G enabled devices in a variety of ways without them needing those skills. But I think that education piece, I think, opens up perhaps one of the final areas we should talk about, which is, generally some of the barriers here to us taking forward some of the 5G use cases. So I think we'd all agree there's no shortage of fabulous ideas, fabulous use cases for 5G, and every testing and trial program that's been set up has come up with some really creative ideas. The challenges are the adoption ones and the barriers to those adoption. So we've touched on some of those, some of the commercial issues. Education is another issue, and I think, as we mentioned right at the start, it's not just education of the citizen, it's education of the people who are implementing those solutions, that these can really work, that you can provide a service as a local authority, you can provide a service through these technologies. So it'd be really interesting to explore education generally as a barrier and an enabler to adoption, but also to hear perhaps about some of the other obstacles and barriers that you've come across and how you've overcome them in trying to get 5G solutions out there. Anne?
Yeah, I think obviously funding is a big problem. Gary said, that they're looking for, and I'm just making up my notes here, stackable use cases for commercial, because certainly for health and social care, we've decided that you really need a ubiquitous coverage so that you're not missing anybody out. You've got to offer it to everybody. And that then does cause some problems financially, and who's going to cover that absolutely everywhere. And certainly in some of the more rural areas, there will be places where there might only be one or two households, and then it's very difficult to get a stackable use cases in those scenarios. We're working at the moment in one of the poorest wards in the UK, and we've got a similar problem in that people can't afford to have connectivity. So there might be plenty of it around in theory, but in practice they can't afford it. So we need to make sure that we've got a business case that is sustainable, and that's something that we're very much working on in our current 5G Create testbed and trial, to try and look to see what other municipalities, other authorities could do, what's needed to have your own in-house, if you like, private 5G network for health and social care. Yes, we get, as you said, we can show reams and reams of benefits and reams of how it's improving things. But what we've got to do is to try and get some money and find out. I think the running costs are actually quite a lot less than people are paying. It does open the whole doors for increased data usage. So some of the more, scans being done in the back of ambulances, etc. Then it's the data usage in that is so high that under the current financial model that the MNOs have, the NHS haven't even started looking at it because it's just too expensive. Whereas if you look what's happened in certain, certainly the VA over in the States with their Veterans Association, their health service, they're doing a lot of remote scans, and it is getting, it is a lot circulated around. So they're not constrained by the same model finance model. So that to me is one of the biggest ones we've got to resolve, is how and I suppose who pays for it all.
Nick, anything you'd love to add in that area?
Yeah, I think we've done a lot of work working with the community, and the part of our many team got some really good members of the team who've done a lot of community engagement, and I think whilst that's been really effective, that's also been challenging during COVID as well, and I'm sure everybody else has found that. So I think understanding what individuals and people in the communities needs, that's certainly an area that we've tried to focus on, and that's been sort of one of the biggest challenges. And we talked earlier about people's digital skills. I think Gary, you mentioned that. So again, that's another factor that we've tried to understand. We've tried to, when we've liaised with communities and individuals, tried to understand what their individual needs are and where we can support them as a project, even to take part in the project as part of the trials. So where we can support that from both provision of technology and also enhancing digital skills. So I think that's a big area of challenge generally, because sometimes, like you say, some people are a little bit resistant or perhaps don't want to admit that they don't have that experience or that knowledge. But it's encouraging that we've found it encouraging that people have come forward and have said, well, I do need some support in this, but I would like to take part. So I think really, getting in amongst those in the community and properly understanding their needs, I think that's probably the biggest area of challenge really, and bringing people up to speed in terms of digital skills certainly is a big push that we're looking at from a project point of view, and from certainly a local authority point of view as well.
So it's been just relating that back to COVID. So one of the things we've been doing in the West Midlands, and maybe it's happened elsewhere as well, is that one of the benefits of COVID is that many more people have started to use and adopt the NHS app, or to be comfortable using apps that have come out from the NHS. And when you start thinking about what's the motivation and how do you get people confidence in using the technology, it's the healthcare applications that really can potentially push people over that edge if they've got doubts about the value and the need for technology. I'm not suggesting it's a panacea, but certainly we've managed to attract a whole raft of colleges in the West Midlands to support that.
Just thinking about what you were saying about sort of barriers and education and that, I think that sort of engagement and working with stakeholders is really key, and that's something that we found in that we've worked with a lot of care providers as an independent intermediary. And when we first started doing that, it was quite interesting, because what a lot of them said to us is, we know we need to be doing more with technology, but it's not our world, it's too hard. And every time we try, all we get is people trying to sell us things. And I think there is an opportunity, I think now, to do more to support the care sector collectively in looking at how they can access connectivity. And in turn, that helps to get them engaged and to train staff, and then open up more opportunities for the technology.
5G has huge potential, but I think we mustn't lose sight of the fact that there are going to be new services available from satellite constellations, LEO satellites, for example, the likes of Starlink and OneWeb, that will be able to provide coverage in areas that, even with the SRN being added to the way that we do things at the moment, there are still going to be many people who aren't going to have good quality mobile coverage. And so being able to do these different approaches to layer them on top of what we do will allow us to get people connectivity, but it won't address the affordability challenge. And this is why not necessarily the view of Dorset Council or the 5G Rural Dorset project, maybe more a personal view from Gary, is that there is a need for some intervention to deliver people with the essential connectivity that they need to help local authorities and health services to deliver them the care that they need. It's a self-reinforcing argument, really. We'll save money by doing it. So it's a little bit of a spend to save. They don't have to be able to use that connectivity to watch Netflix, but they do need to be able to to feed the tools and devices that are needed to help to take care of them. And that's where I think we need to go.
So I'm going to suggest that we stop there, and I'm going to say thank you very much to the panel for the discussion. I'd love to do another one of these sometime. So very enjoyable. Thank you very much for your contributions.